Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, a place where ER docs, aka emergency physicians, come and talk about things that are important to us. They could be personal, silly, relevant, professional. Right now, we're talking about coronavirus like the entire rest of the world. And I've got Salim Rezaie, and he's the smartest guy I know. Okay, I have to just tell you that he's the smartest guy I know. And so when I have questions, I always go to Salim, and he's tuned into the research, and I can always ask him a dumb question, and he doesn't seem to mind. So thanks for coming. And I know you're busy. You're on doing something else today, so I'm going to jump right in. Okay,
let's do it.
I wanted everybody is all over the map about case fatality rates. I mean, when we first started, I heard numbers as 3, 4, 5, New York 10, Italy was 10%. It was crazy. And now they're looking at California, looking at 30% of the people being positive. So case fatality rates are way down. So, oh, wise one, give me your best give me your best guess. It is a guess, but give me your best guess what you think the real case fatality rate is.
We have to be really careful with the numbers that are getting thrown around. So people have to remember that in order to figure out what a real case fatality rate is, you need to know what the real denominator is. In other words, how many people are testing positive for that test.
Right.
And the big issue, at least in the United States, is that we've just not had enough testing to do population level testing. So all the numbers that we're using, this denominator, are people that are symptomatic. So that's all we know. But we also know, reading through the research, that there's anywhere from 20 to 40% of people who are asymptomatic that are not getting testing. And if you add those people to that denominator, then the case fatality rate's actually going to be lower. So in preparation for this, I actually went to the Johns Hopkins site and I just looked at the numbers real quick. And so as of this morning, we have 869,172 cases of COVID-19 in the United States. And if you look at the deaths, it's about 49,963. So if you do a simple calculation, that gives you a case fatality rate of 5.7%. And that's probably higher than what it actually is.
Because how does that? Okay, wait. Okay, how do you incorporate this the Stanford study that says 30% of the people that they tested were positive? Isn't that going to drive that down into the fractions of a percent?
That's correct. And so the best example of this we have, I call it the worst perfect experiment, was the Diamond Princess cruise ship.
Right.
That's the perfect lab test, which I never want to lab test humans, but it's an unfortunate thing, but there was 3,711 people on that ship. 355 of them were positive for COVID-19 as of February 16th, and only 7 of them died of those 355. So that gives you a case fatality rate of like 1.9%.
Right.
And the reality is that when we're doing, physical distancing, we're probably driving this number down even more. And so my best guess is we're probably going to be under the 1% to about, let's call it 1.8% if we had enough tests. That's kind of what I think. Yeah.
Yeah, that range. Yeah, and it could be lower, could be, depending on. Here's a question for you. Do you think the case fatality rate in California is going to be different than the case fatality rate in New York City?
I do, and we'll talk about that a little bit later on when we get into talking about social distancing and whether that works. And the main reason I think it's the case is that, New York has a central transit system.
Yep.
And California doesn't. We don't have it here in San Antonio. So that definitely is going to play into the number of people who are going to test positive. The other thing is that when I'm doing social distancing in San Antonio, we live in hill country out here. So we have acres of land between houses. And, you add social distancing to that, that also is going to have a huge impact. How do you do social distancing in New York when you live in an apartment building with 100 other people on one ventilation system?
Right.
Just by staying home doesn't mean that you're not going to catch the damn virus.
Yeah, exactly.
So I think we're going to see, these rates be all over the map, and there's a lot of things that go into that. And, that's part of it is just, the environment that you live in, how do people get around, those sorts of things.
Yeah. I had a case just the other night where Elderly guy came in, classic fever, cough, everything, and we did the spacesuit thing, and took care of him. And sure enough, surprise, surprise, he's COVID positive, and he swore up and down he lives alone in a basement apartment. He doesn't share a kitchen. He doesn't share a living room. He's an elderly guy. He hasn't been out in several weeks. And I'm thinking, only way I can see this guy getting it is through the ventilation system. I don't know how in the world, I suppose somebody had something on, I just don't know how he got it. I don't know how.
The other piece of this is that this drives me crazy. We talk about, frontline healthcare workers and, our chance of picking this up. And it's a real risk, and it's just part of the job. But the problem with a lot of these studies is they're making a huge assumption, and that assumption is that we picked it up during aerosolization or something while we're in the department. But how do you know you didn't pick it up when you went to the grocery store? How do you know you didn't pick it up when you turned a doorknob that 50 other people touched? How do you know you didn't pick it up by pushing a button on an elevator? We just don't know, and so I think, and I'm really big about this, is like, I think when we initially started doing this, we were using all these like triage screening tools, and I think they're a setup for failure. I mean, this virus has proven time and time again it can do whatever the hell it wants, and it's not all respiratory, and it's not all about travel.
Yeah, we'll talk about that in a second. Yeah, I'll get to it. We're only in question two. Question two, the Chinese say that there's 20 different strains. You think so? You think they're telling the truth there?
I don't trust anything that comes out of China.
It's like a true Texan.
Yeah, I think it's another podcast for another day. But look, I think take it with a grain of salt. This is an RNA virus. We know RNA viruses are very prone to making mistakes, and mutations can happen. Whether there's 20 strains out there or not, I think still remains to be seen. It's possible, but why do you think, people are putting theories out there that, well, maybe this is why Italy's mortality rates are so high and New York's mortality rates are so high. And, I don't think it's because there's 20 strains of this virus and they just happen to get a bad strain of it. I think it's just that their systems got completely overwhelmed and they got caught with their pants down, so to speak. They just weren't ready. And it's unfortunate, but it's been really good to get the information from those places. And I think the difference in their mortality rates has to do with how they live and the fact that they just got slammed and just weren't ready for it. Whereas many other places, we've been able to prepare because we didn't get that initial onslaught.
There's a lot of New York doctors are going to really take issue with that. I can understand, Italy. I mean, I've spent a lot of time in Italy, and you've got an elderly population that's living on top of each other. They all smoke like chimneys, and I can understand, the elderly patient dropping out, in Italy. What I don't understand are the younger people who have this crazy cytokine storm that is completely overwhelming people. I want to talk about, and that's a segue to this idea of is this a blood disease or is this a pneumocyte disease? People have talked about the heme molecule and porphyrin replacement and so on. So other people have said that that's bunk, and I'd like to hear your thoughts on it.
So look, I initially drank the Kool-Aid on this too, because we were trying to figure out how we were seeing people with oxygen saturations in the 40, 50, 60% range and texting on their phones. I mean, how do you explain that? It's just not compatible with life when you think about that. And I thought that was a nice theory to maybe explain that. Right. But there's a few things that I think are important for people to understand. So to answer your question just simply, I think it's a bunch of junk. It's not a true cause of what's going on here. So the first thing is there was this preprint paper that came out that hadn't even been peer reviewed. It talks about COVID or SARS-CoV attacking the beta-1 hemoglobin subunit. And people have to understand that study wasn't a human study. That was a molecular docking study that was theorizing that maybe this is one of the reasons, and there was no extrapolation to humans. So that's the first thing. The second thing is that clinically, when you're working and you're seeing these pulse oxes and you're comparing those to ABGs, they match.
Yeah,
they match. There's no, like, it's not like methemoglobinemia where you'll get this really low pulse ox and then your ABG doesn't necessarily like correlate with that. They're matching. And so there's a huge discrepancy in what we're seeing clinically to have this hemoglobin be the theory that's the primary driver here.
Yeah.
And then the final thing I'll say, and this has not gotten as much traction, is there was a rebuttal piece that was written to that original paper. And I thought they did it. It was a lot of it was over my head because I don't do molecular docking studies. But their point is that what they were targeting was the wrong thing. They looked at the wrong thing to target. And so therefore it completely dismisses that theory altogether. So I think it's a bunch of junk.
The thing that bothered I thought it was a distraction from one of the larger. I did a study of some tissue studies, post-mortem tissue studies that were looking at essentially microemboli, embolization or microvascular occlusion, in which basically you were seeing, a PE. You were seeing people block off their capillaries and we know that we have coagulopathy. So it makes total sense that you would they would behave much like a PE, where they're chopping off pieces of their pulmonary tree. So I kind of think you're right. But the question here is why the plasmapheresis, the blood exchanges. What are we doing there? And that seems to have had some benefit. Is that from adding back in coag factors, taking out inflammatory cytokines, that kind of thing? What are we looking at there?
Yeah, so I think the biggest thing here is, you're basically getting at convalescent plasma therapy or plasmapheresis is another, way to think of that. And so what the thought is so first of all, this is not a novel concept.
Right.
We've been doing convalescent plasma therapy for many, many years for many, many other illnesses. It's been tried in diphtheria, scarlet fever, pertussis, and it's even been tried in Ebola from my readings. And I guess let me take a step back and say that, what we're trying to do is we're saying somebody has this infection and they recover. And hopefully there is some antibody or immune response to that. And what we're trying to get is we're trying to get their IgG, their long-term antibody. And what we're trying to say is that you've now recovered, you're convalescent. And we want to take your IgG and we want to infuse that in somebody who maybe doesn't have that antibody yet to help them kind of fight this infection. And I think in the short term, while we're waiting for all this research, randomized clinical trials and trying to find things that work, I think this makes a lot of sense. It's not crazy. It's tried and tested in other disease illnesses. And I think this in combination with steroids, earlier on actually is a really nice strategy, at least while we're waiting.
Yeah. I want to talk to you about intubation. It seems like intubation is a kiss of death in these patients. Depending on when you intubate them, is the percentage of them that die. Are we waiting too late? Are we intubating too early? Are we sealing their fate by intubating them? Is it all about high oxygen saturations by treating them with a gamma bag, modified CPAP? What's your feeling about that?
So I think the message I want people to understand here is I'm not advocating for not intubating patients. If we could just take a step back, I think to keep it simple, we never want to intubate somebody who doesn't need to be on mechanical ventilation, but we also don't want to wait so long that we're not intubating somebody who does need it. And that is quite the conundrum. It's one thing to say it, but to clinically decide on it in a new disease is really tough. And the thing that makes it even tougher is, ED docs, we're great at thin slicing. You see somebody, you remember like your last COPD experience, you know who is not going to do well. You just remember these things. And this is a new disease that's not fitting into anything that we would thin slice. I mean, these people have these pulse oxes that are just absolutely ridiculous. And so I think the point here is that we can't use pulse oximetry alone. To make that decision. And so we're having to get comfortable with people having these lower oxygen saturations than we've ever done before, because you and I both know somebody coming in with a pulse ox of 50 was what, 6 months ago would have been intubated. There's no question.
Yeah, and when you see that, you're just kind of, I can't leave the room. I'm like standing there with my laryngoscope and my tube, and I'm thinking, okay, when am I going to do it? you know?
And so really there's two things that we're trying to fight here. So one is do we just leave the person alone and let them just keep breathing and working? And that's not a good thing because they can get something called self-inflicted lung injury, or
Sure.
SILI, which is a hilarious acronym because there's nothing silly about it. But essentially
No.
they're working so hard that the transpulmonary pressures in a negative way are just causing more and more damage to those alveoli, and can potentially exacerbate an ARDS further down the line if we do nothing. And
Right.
so many people are trying to figure out, is it work of breathing? Is it respiratory rate? Is it mental status? Is it the fact that they're anxious? Are they getting diaphoretic? There's a lot
Right.
of things that go into it. It's not just the pulse ox. On the other end of that is we know that the downstream effects of putting people on mechanical ventilation is not a benign thing. They can get something called ventilator inflicted or induced lung injury, which is VILI for short. And the reason this is important is it's the complete opposite pressure gradient. It's a positive pressure system, not a negative pressure system. And I've yet to find studies that have shown that once you've intubated somebody, you have a mortality rate of better than 50%. Most of them
Right.
are in the 70 to 80% range. The
Right.
question that still looms is it the ventilator itself and the strategies we're using that's doing that? Or is it that they were just that sick anyways, and that was
Right.
going to happen anyways? And so
Right.
I think this is kind of the conundrum you're basically getting at.
Yeah. Yeah. I know that the docs in New York are beating themselves up because they think I intubated too early, I hurt the patient. I intubated too late, I hurt the patient. And you're absolutely right. Trying to figure out the optimal time that your hand is forced when people look so different. We've never seen this before, never. And my heart goes out to the clinicians who are they're looking. I kind of make a light of the fact of how I would be in that situation, but the truth is, it is maddening. It is absolutely maddening to watch these patients go down and
And
not know.
I have I meant nothing bad about my comments about New York. We are indebted. This
Right.
country, this world is indebted to everybody on the front lines in New York,
Yeah.
because the amount of information under such dire circumstances with huge volumes, with just resource allocation, the number of people getting sick, we are indebted. Every single one of us is indebted to them.
Yeah, that's for sure. Let's switch gears. I want to talk to you about, we are not talking about politics, but I want to talk to you about hydroxychloroquine. And, why on earth did that come up at a presidential press conference and get the stamp of Trump on it? I don't know, but we're not talking about that. Okay. We're talking about the French study that looked at viral loads and it made the claim that hydroxychloroquine lowered viral loads. In my limited search, have not seen anybody who's tried to replicate that. I have seen people try to say hydroxychloroquine does or does not work, and it's used in the cycle and yada yada yada. But nobody has tried to really say, did the French study tell the truth? Did he really lower viral loads? Do you know? Have you seen anything?
I have. There's a lot of studies that are coming out now on this, and just to take a step back, I think the answer is going to probably be a little bit more nuanced than black and white. So
Okay.
let's think about the mechanism of, like, why does hydroxychloroquine even work? Because it's not an antiviral.
Right.
Uh, and so the way we think it works is it alters the pH
pH.
of the extracellular environment. And when you alter that pH, it doesn't allow SARS-CoV-2 to bind to ACE2 receptors. That's the thought behind it. So the reason this is important is that just from a mechanism alone, once a person is infected and they are viral replicating and they're kind of into it in terms of their illness, I question whether hydroxychloroquine is going to work in that situation, because just by its mechanism alone, it doesn't make sense. The
You
second
think
thing
the
I would
French study? You think the French study was inaccurate? Poorly? Have you looked at it? The
I
selection
have
bias?
I have. And that's the other thing, is we don't know when exactly they enrolled those patients. We just don't know. Was it too
Right.
late? Was it too early? That's the first thing. The second thing I would say is that, so what if we reduce the viral load? What is the patient-oriented outcome on that? Just because you lower a viral load, does that extrapolate to patients doing better? Does that decrease mortality? It sounds good on paper, but hydroxychloroquine's been used in another viral illness, chikungunya. is actually what it's been used in. And the in vitro studies showed that we do reduce viral loads when we use it. But then when we started using it in humans, that didn't extrapolate. They actually
Interesting.
had worse outcomes. And so we have to be really careful when we're looking at this stuff. The other thing I would say is that these are not benign medications. There are more and more reports coming out of people having blindness from hydroxychloroquine toxicity, prolonged
But
QTc.
aren't they high? I mean, I'm just trying to be fair here. Aren't they? I read a study that they had these were only after like 7 years of treatment. I mean, people take this for years with people with lupus, and but the dosing is like 200 milligrams a day, and some of the dosing I've seen in this have been like 600 a day. So yeah, sure.
So that's exactly what I was going to get to is that, that was my next point is we don't know what the ideal dose of this is for
Yeah,
COVID-19. We don't know.
yeah,
And people are using this like ridiculous dose that is not benign. And so I agree with
right.
you. It's a valid point. I think there's just a lot more that we have to learn about this before we just willy-nilly start giving it. And look, Mark, me along with everyone else, I'm the first one to say we needed a treatment 5 months ago. And our nature as ED docs is to do something, not just
Right.
stand there. We want to help. We don't want to stand there helpless. And I'm not trying to put gloom and doom on this, but when you do things, you make a very big assumption. And that assumption is that the thing you're doing is actually causing benefit. And
Right.
oftentimes we forget about the potential harms. And how many studies have you looked at where iatrogenically we're hurting people or we're killing
Right.
people because mistakes that were made? And so all I'm advocating for is not that hydroxychloroquine doesn't work. It may very well turn out to be a very nice prophylactic medication. I think that we need to figure it out in the early stages of the disease. And I think we need to figure out what the optimal dosing and timing of this medication is before we just start throwing these ridiculous doses.
600
And
milligrams. Wow.
yeah,
When I
I
read
mean,
when I read that, I thought, no wonder they're running into problems.
yeah, so
Yeah.
I agree with you. And I'm not against hydroxychloroquine. I just think it's not been studied in the right way or at the
Right.
right time of this illness yet.
Yeah. What about ivermectin? Hey, you've read about ivermectin?
Yeah, that was also an in
That's
vitro
kind of a dumb
study.
question. You've read about everything, so
Yeah, it's a single,
yeah.
in vitro study. It again, same thing. It showed decrease in viral load, but I don't know what that means for patient-oriented outcomes. I think, add
Is it
it to a potential interesting medication that may turn out to be a nice prophylactic medication. Again, just the way it works, I don't think we're going to see it as a true treatment.
is it true treatment? Yeah. What about the antivirals? You think that remdesivir was a lot of selection bias in their initial study? That I saw a lot of stuff criticizing how that worked. What do you think?
So, I'll tell you from a treatment standpoint, let's not talk, I don't want to conflate prophylaxis with treatment. I think from
Sure.
a treatment standpoint, the two medications that make the most sense to me are remdesivir and lopinavir/ritonavir. And they do have some body of evidence before COVID. So remdesivir was used successfully or maybe mixed a little bit with MERS and Ebola.
Hmm.
And then lopinavir/ritonavir, which I think the trade name is Kaletra, if I remember correctly, has been used successfully in HIV. The few trials that we've gotten, and some people may argue that that remdesivir publication in New England wasn't a trial. um, so let's start with remdesivir. So they basically took a bunch of pre-selected patients,
You're right. That was
and
the problem that I saw
yep,
in it. It
and they
looked like
said, here's some
selection.
remdesivir. We're going to use it for compassionate use, but you have to meet all these criteria to use it. And by the way, there was this like 68% improvement. But when you do that and you have no placebo arm in a self-limited disease, was it the medication or something else, or was it the disease just getting better on its own? So
Yeah.
I'm not shooting down remdesivir. I'm just saying
No.
that study doesn't answer the question. So
Yeah.
I think more evidence needed.
Yeah.
The lopinavir/ritonavir study, which was a true randomized clinical trial, the question becomes is, was it given too late? And these were people that were end stage. They
Right.
were doing everything that they could, and they randomized people to getting it or not getting it. And although the headline is it didn't work, there's some signal in there that's very hypothetically interesting. And a 6% mortality difference as a secondary outcome is very interesting to me. It definitely catches my attention in a disease that we have no treatment for. I
Yeah.
can't say that it's actually going to do that, But I'm interested to see if we use this medication at an earlier time point in the disease illness and not so late, that we might actually see some benefit as a treatment option. So I think the jury's still out to answer your question, but I think these two as treatments have potential.
Yep. Yeah, I agree. I agree with you. Tell me, okay, this is where I know so little. Let's talk about cytokine storm. They must have invented cytokine storm after I left medical school and after I quit reading all the research journals, because this is not, obviously I understand the inflammatory cascade to some degree, and but they start dealing with the acronyms of IL-8 and this, that, and the other, and I go, what the? I understand interleukins and whatnot, but this is still, it's on the edge of my understanding. Tell me a little bit more what you know about interleukins and cytokine storm.
Yeah, so to be fair, and I always like to be fair and transparent when I answer questions, these are not medications that I've ever prescribed. I'm not treating people that are in cytokine storm down in the ED. These are things that are done on the HEMONC services and things that are done in the ICU. But with that caveat, there's a therapy that is currently used for B-cell lymphomas and malignancies, and it's called CAR-T, is what it's called. It's chimeric antigen receptor T therapy. And they use these medications to basically induce killing of these cells. And when you induce killing of these cells, they start secreting all this stuff. And then the inflammatory markers like IL-6 and IL-2 and TNF alpha, they all start getting ramped up and they start going crazy. And that's where you develop this cytokine storm. So one therapy that's out there that people are talking a lot about is a medicine called tocilizumab, or tocilizumab, however you want to pronounce it. I believe the correct pronunciation is tocilizumab. And the way this medication works is it inhibits IL-6. And IL-6, we think, is one of the primary drivers of this cytokine storm that happens with patients. And so there's lots of people that are thinking that in the patients that are kind of later stage, who are having this cytokine storm where these other treatments may not work, this may be a therapy that can potentially show some benefit in those patients. Now, as of today, my reading of this is that most of this information is extrapolated from oncology research. I have not seen anything on COVID-19 specifically, or cytokine storm induced by COVID-19. And so the biggest issue I have with this medication is how much it costs and how much availability is there going to be of it for people that maybe work in smaller shops or who are in resource limited settings. And so I think that the applicability of this medication is it may work, and there's good theory, sound theory behind why that is. But the reality is like, how widespread is this going to be available for everyone?
Yeah. Yeah, I happen to agree with you. Right now, it seems like everything is headed to New York, and it should be. It should be. I know they're coming down. It is interesting that New York seems to be on the upswing. Hopefully, I've been watching hospitalizations, and they're now in the negative. They're discharging more people than they're admitting, which is a miracle. Thank God.
They needed it. I mean, they really needed it. They needed some breathing room.
Yeah, which now brings me to my last question here about social distancing and the real purpose of it. Initially, it seemed to me like was to get us some breathing room, some space to keep our hospitals from being overwhelmed. And you're not an economist, nor am I, and I'm not arguing from economy. Okay, that has its own issues, and we'll leave that to the economists. But the question here was medical. We instituted pretty draconian social distancing measures. My understanding was so that we didn't overwhelm our hospitals and people would die because we couldn't get them on ventilators. That's clearly not going to happen. At least it does not appear that that's going to happen now. So with that, not as a medical indicator, do we now have less indications for the draconian social distancing that we're doing?
So a couple of things here. I'll answer your question, I promise, but there's something that I think is important for me to say, because I think our initial intentions with I call it physical distancing. I know I've said social distancing a few times. It's like never been more important to be socially connected. So we're just like physically disconnecting ourselves. But that aside, you know, I feel like we had good intentions in our messaging of stay home. And my concern now is that I am starting to see people coming in who had MIs the week before or strokes 3 days before.
Right.
I've never seen so many people with appendicitis that is ruptured,
Right.
DKAs that are just late stage, and the
Right.
list goes on and on. And I think that the initial message was some of our own fear, which was not malintentioned at all, but I think that we were so clear in that messaging that we've now scared people that they would rather die at home, which is what's happening, than come to the emergency department. And that's not what any of us signed up for. We signed up to be a safety net for people. And I think we need to dramatically change our messaging to the public. And that is that if you think you're having an emergency, come to the emergency department. We will keep you safe. We have workflows now. We have
Right.
put things in place to take care of you. Do not be scared to come. But we don't have enough tests to test everybody for COVID-19. So don't come to the emergency department for COVID-19 testing. I think it's a bit nuanced, but I think it's a really important message.
Yeah.
The second, go ahead.
Go ahead. No, you. Go ahead.
Okay. The second thing I'm going to say is that we cannot continue to keep this country locked down the way we're doing it. I think initially, as we were waiting for things to kind of pan out, I think it made sense. But I think that to answer your question, you have to look at the prevalence of disease in the area that you work. And if you're in an area that's high prevalence of disease like New York City, I think it's not a good idea to maybe start opening things back up too quickly, because there's a real thing as a second surge and there's no wiggle room for mistake. For me in San Antonio, where I'm just not getting crushed and our prevalence of disease is low, I think it's time to start opening the doors a little bit and maybe do kind of a soft opening. Maybe, the people that are least at risk, or, just opening things up a little bit to just test the waters, because we have breathing room. We can take on a surge, not to the level of New York, but it's a nice little biopsy of what other places can maybe start to do. So to answer your question, I think it depends on the prevalence of disease in your area. If you're a low prevalence of disease, I think it's time to start opening doors.
Yeah.
Now, this doesn't mean to have a big Mardi Gras or a big party where everybody gets together.
Where they're all
right?
slamming each other.
Yeah, I think we need to be really careful how we do it, and we need to be very judicious in how we do it. And I would argue that when we initially applied these type of bans, it was because we simply just didn't have tests to test people,
Right.
and we didn't have enough PPE. And there's still lots of places that don't have enough tests and don't have enough PPE. But I would argue that we are far better off now than we were 6 weeks ago as a country.
Yeah.
And that's going to be different depending on where you work. And I think the places that have the availability of tests, who have enough PPE for themselves, it's time to start doing some soft openings.
Yeah,
I hope that answers your question.
Yeah, no, it does, because if you look at, I haven't taken calculus in a while, but the area under the curve, a spike versus a broad-based hump may in fact have the same numbers or very similar numbers under the curve. And so the idea that we were actually, especially in a disease where we really don't have any treatment for it, the idea that we're going to save lives by spreading this out is probably mathematically and epidemiologically incorrect. The same number of people are going to die over 3 months as opposed to over 3 weeks. And the 3-week scenario would have overwhelmed us and would have added to that by having people who died because we were resource restricted. So the idea that we were flattening this thing out was solely to allow us to have some breathing room so the hospitals and the doctors and everybody is not overwhelmed. It did not, and probably will not, change the number of people who actually end up dying, because we're not really effectively treating it until we have some sort of treatment to that effect. That's number one point. And number 2 point is, if I can reiterate just some personal experience. The other night, I just saw so much personal violence committed against people, whacking each other. I saw like repeated, right hand club to the head kind of thing going on, and it was my mother hit me, my sister hit me, and split my head open with a Lysol can, and we know that suicides have gone up, family violence has gone up. So I think that it's not without risk. And if we look at it and we say the steps we took were to prevent overwhelming a particular hospital, we're not going to overwhelm the hospital. Okay, we may not save lives. They may continue. We may have deaths a month from now, but it's not like it's not like it was without risk. And now we're seeing what those risks are. The delayed diagnosis. I saw one the other night, same sort of thing. And I keep telling people, and the guy told me he didn't come in because he was afraid.
Yep.
And I said, dude, you should have been treated about 3 or 4 days ago, and maybe even before that, and we could have helped you out a whole lot more. So I hope that message gets out, that from a medical perspective, not an economic necessarily. I mean, I'll deal with the economists and the politicians. From a medical perspective, we're okay. It's not going to change anything if we open up. People are still going to die. Probably the same number are going to die. We're not going to overwhelm anybody. It's going to be ugly, no matter how you look at it. But there are other issues to bear.
I fear that we've crossed a threshold now where what our initial intentions were, which were good, are going to start crossing with the, I guess, collateral damage of non-COVID things that are going to start happening. And now you're going to have people with heart failure for the rest of their life, or neurologically devastated and won't be able to work. And for all the things that we were trying to focus on during a pandemic, we neglected all these other things that are non-COVID in our messaging. And I'm just as guilty as everyone else. I'm not blaming anybody, but I think we're at a point now that we need to really emphasize that messaging to people, that we will keep you safe and we will take care of you. And if you think you're having an emergency, please do not hesitate to come in.
Yeah.
I think if you're coming just for COVID testing, I still don't think we have enough tests to do that. At least we certainly don't in San Antonio.
No, we don't either. But and it's important to reassure people that we have ways of isolating the people who are potential COVID positive patients. We don't mix and match, so you can be sure we've got whole sections of the ER that are dedicated to COVID, non-COVID, and it's not perfect, but chances are you're going to get it. You're going to get it. That's the other message.
At some point we're all, not all, but like 80% of us are going to have this. And that's another, we didn't get into this, but like with physical distancing, how long are we like keeping this thing at bay? Because you got to develop herd immunity at some point. And by physical distancing, you're really putting a crutch on that in terms of prolonging that. Look, physical distancing, no physical distancing. People ask all the time, how long do you think this is going to be around? This is not going away for a couple years. No, this is something we're going to be dealing with for a couple years.
And it actually, in the long run, I'm going to go out on a limb and say this: in the long run, it might be better for us to take our medicine this spring and summer rather than have a whole bunch of people who are naive go into the fall and see COVID part 2. I'd rather take my licking now. We've got the hospital capacity, we've got everything else going on here. I'd rather go ahead and jump in and take it now than see another cold, dry weather, surge.
Yeah, and this is, the whole looking at your prevalence of disease in your area. I think if you're a low prevalence of disease, this is the time to start doing your soft openings before we get to our next winter. And for the places that have no breathing room, that may not be as good a strategy right now, because they can't take it. I mean, it's not that they don't want to, it's just there's only so many ventilators, there's only so many doctors and nurses, and there's only so many things you can do. There's only so many beds.
They're pretty tired. William, thanks a lot. I always love talking to you, and this is very enlightening. I hope I haven't taken too much of your time. So
never.
Everybody, this is where ER docs come to talk about the important stuff. So come back and join us at EP Talk. Thanks a lot. Thanks, Salim.
Thank you, Mark.